I don't know if this, they'll get it. Okay, great. Well, okay, awesome. Hey, good morning, everybody. Really happy to have you all here, and thanks for coming to this course. The guidelines that we put together and that were released a couple months ago were just a huge amount of work, and we're really proud of them. And so to be able to have this opportunity to help disseminate the guidelines and have you all here, it really does mean a lot. We do have the kind of the usual, some random stuff to go through, so I'm going to do that. This course utilizes the audience response questions. To participate, you will need to scan the QR code located on handouts near the entrance to the meeting room or on the screen. The AUA 24 Annual Meeting mobile app is available and is free to download. When you download the app, you will be asked for a username and password. Course materials are available on the AUA 24 website and mobile app. Use the email that you use to register. Your password is your AUA ID. You can find it on your registration badge. AUA policy states that all planners, authors, and presenters must disclose to the AUA prior to their presentation all relevant financial relationships with any ACC-ME defined ineligible company, formerly known as a commercial interest. The AUA determines if the relationships are relevant to the educational content and mitigates any conflicts of interest prior to the educational activity. Disclosures or relevant financial relationships are posted on the AUA's annual meeting website, auanet.org, annual meeting, and a link is posted in the mobile app. Please remember to silence your cell phones. No photos, video, or audio recordings are permitted. For reals? If you can take photos and blast them all over Twitter, can't we? And from our standpoint, it's kosher. So it's fine, please. Courses are selected based on evaluation results. For every course evaluation that you complete, your name will be entered into a drawing for complimentary registration for AUA 25 in Las Vegas, Nevada. You can evaluate this session by selecting Evaluate through the credit claim process and going to the AUA 24 mobile app, click on the CME button, or go online and click on the CME page. All right, well, that's the house business. So again, really welcome to everybody. Okay, let's see, this mouse is not, I guess it's not a mouse kind of a thing. I found it. It's a remote kind of thing. We're going to start with the other one. It's the other, yeah. So we're going to we're going to have audience response questions, but I'm going to do a little intro first. Great. So again, welcome everybody. We're really glad to have you here. I primarily wanted to start by introducing everybody. They're in perfect order. Dr. Steve Bourgeon on the end. Steve, yeah, see, looks like the guy there. Chair of Mayo Clinic, chair of urology at Mayo Clinic, and really an amazing thought leader. So happy to be able to have you here. Dr. Sophia Cameron, who's at MGB, a associate professor of radiation oncology, director of diversity, equity, and inclusion, an amazing contributor to this guideline, and also active in so much research in radiation oncology. And so thank you for being here. And Dr. Scott Tagawa, who is really came in clutch here because though he was not on the guideline, he kindly was willing to participate in this course because we need an expert medical oncologist, and he knows this guideline and this space inside and out. He's professor of medicine and urology at Weill Cornell. Richard A. Stratton professor. Thanks Scott for being here. Yeah, sorry, I didn't introduce myself. That's why I put this slide in there. Todd Morgan, Chief of Urologic Oncology at the University of Michigan. I was chair of this Salvage therapy guideline. And again, welcome. I'm going to put my disclosures up here. Everybody has their disclosures when they get to their talks. Nothing that really has any significant overlap with this guideline. I also want to go over the learning objectives. Specifically for this course. Number one, to understand the therapeutic options available for recurrent prostate cancer following primary therapy with curative intent, to enhance the ability to interpret biomarkers and imaging to accurately detect and monitor recurrent prostate cancer, incorporate shared decision-making into clinical practice, considering the patient's preferences and potential impact on treatment on quality of life, and to understand appropriate use of molecular imaging, metastasis-directed therapy, and systemic therapy in patients with biochemical recurrence. All right, so these are the objectives. Now you know us all. Now we get to do the audience response questions. That we can flip over to those now. And please scan the QR code that comes up. We're going to go through these. These are really important for us, for the AUA. Hopefully you get some good insight from doing these questions. Here's the QR code. So these come up now, and then you'll be asked after the course to go into the app and complete these again. So this is the pre-test form. This is the pre-test. We'll get to the post-test. I'm going to stall for a sec while we get these going. Make sure. Anybody need more time? Almost. One camera's up. Okay, here we go. Question 1. A 60-year-old man has a PSA of 0.1 nanograms per mil, 6 months after a prostatectomy with final pathology showing grade group 3, pathologic stage 3A, N0 cancer with negative surgical margins. If his PSA continues to rise, salvage radiotherapy should be given before which PSA threshold? Less than or equal to 2, 1, 0.5, or he should have already received neoadjuvant radiotherapy. Oh, I don't know why, yeah, I think that was a typo. It should say it should have already received adjuvant radiotherapy. I'm not sure why somehow that got flipped somewhere along the line. We good? Okay, thanks. You're advancing. Thanks. Question 2. What is the minimum duration of hormonal therapy in a patient with high-risk features following radical prostatectomy who is undergoing salvage radiation for biochemical recurrence? A, it may be omitted. B, 4 to 6 months of therapy. C, 12 to 18 months of therapy. D, 18 to 24 months of therapy. Here we go. Oh, yeah, there we go. Got it. Thanks. And if you're just walking in, no problem, just please scan the QR code. That'll stay up there. I think it'll keep showing up. Okay. Question 3. For a patient with a PSA of 0.5 after prostatectomy and a negative PSMA PET CT, which of the following is the best approach? A, close PSA follow-up. B, reevaluate with a different imaging modality. C, systemic therapy alone. Or D, salvage radiation plus or minus ADT. And again, if you just walked in, you can scan that code and you'll get to these questions. Okay. Next question. 65-year-old man has a PSA of 0.4 after prostatectomy, grade group 4, T3BN0 and with negative surgical margins. PSMA PET CT shows 2 positive lymph nodes in the left external iliac region. Which of the following would be the best treatment approach? A, radiation to the prostate bed plus ADT. B, radiation to the prostate bed and pelvic lymph nodes plus ADT. C, radiation to the left external iliac chain plus ADT. Or D, ADT plus abiraterone. All right, question 5. A healthy 62-year-old patient has a biochemical recurrence following primary radiotherapy plus ADT for PSA 11, T1C, Gleason grade, or grade group 4, prostate cancer. PSMA PET CT shows a focus of uptake in the prostate and no evidence of metastatic cancer. Which of the following would be the best next step? Biopsy the prostate and seminal vesicles. Close PSA follow-up with repeat imaging in 6 to 12 months. Initiate systemic therapy or proceed with local salvage therapy, i.e., salvage radiation or prostatectomy. Okay, we can flip over to the other. And can we start the clock?
Okay, so what time?
We'll do 10 here. Yeah. Thanks. I'm going to go back to where we were. I got it. No worries. We got it. I got it. Okay. So I'm going to just walk through the agenda for the course. We're going to start with I'm going to give a little overview, set the stage. Then Dr. Borgen is going to talk about adjuvant and salvage therapy post-prostatectomy and the role and definitions of early salvage therapy. He's then going to discuss the evaluation of recurrence following prostatectomy or radiation and role of molecular imaging. Each of these talks, by the way, is tied to specific guidelines, and so we kind of have these outlined here, but obviously the specific guidelines will come up throughout these talks. Then Dr. Cameron's going to discuss salvage radiation following prostatectomy, including management of the lymph nodes and metastasis-directed therapy. Dr. Tagawa will discuss the role, type, and duration of systemic therapy with salvage radiation. I'll get back to talking about local evaluation and management of recurrence following radiation or focal therapy, and the role of salvage lymphadenectomy, and then we're going to have some time for cases. We'll have time for questions at the end of each talk. We'll have time for questions during cases. We purposely are really trying to keep the didactic portion relatively tight with plenty of time for the cases and for questions, so please don't hesitate to ask questions. For folks who are online, we'll also keep an eye on the questions in the chat box. So as many of you know, there was a prior guideline in the salvage space. It was in 2013. It was the adjuvant and salvage radiation after prostatectomy, an AUA and ASTRO guideline, but it was specific to post-prostatectomy radiation. It covered some key concepts like restaging at the time of biochemical recurrence, thinking just CT scan and bone scan at the time, importance of offering salvage therapy earlier for patients with biochemical recurrence rather than waiting for the PSA to go up, concepts around informing patients about the impact of side effects, impact of salvage therapy on subsequent side effects. But there were also a lot of gaps. And one of the statements in the guideline that really stands out to me, because it's something that we now have a ton of data for, it said, given the methodological weaknesses of this literature, it is not possible to provide guidance regarding the use of ADT in conjunction with radiation. And so this is the type of hole that we could now fill, and it really necessitated an entirely new guideline rather than just an update to this pre-existing guideline. And I want to talk a little bit about how the guideline process works. AUA's guideline process is incredibly rigorous, incredibly thorough. We started with key questions, and these key questions were thinking about timing and delivery of treatment in the biochemical recurrence setting, risk stratification, so which patients have higher risk or lower risk disease in the biochemical recurrence setting, use of hormone therapy, impact on quality of life, use of molecular imaging, a huge deal right now, of course, and this guideline tackles that head on. And then role of metastasis-directed therapy, which is totally linked with this use of molecular imaging currently. The actual process for AUA guidelines starts with planning, literature search, study selection. This is a years-long process. Data extraction and quality assessment that's incredibly rigorous, evidence interpretation, development of recommendations. And the recommendations process starts with small work groups, comes to the whole committee. The whole committee spends a ton of time dissecting each of the possible statements, supporting evidence, and then ultimately it goes out for peer review, which is, again, incredibly thorough. Many of you are already aware of how AUA guidelines work, but there are levels of evidence given for each of the evidence-based statements that ranges from A to B to C. And then there are also degrees of recommendation, from strong recommendation to moderate recommendation to conditional recommendation. And then there are also separate statements that can be expert opinion, where really there's maybe not enough evidence to provide a recommendation that's, moderate, strong, et cetera, recommendation, but there's enough of a consensus to provide an expert opinion from the group. And then there are also some statements that are clinical principles, which is just something that we really, at the end of the day, it's just like a fundamental truth about how we see this disease and how we should be managing it. In terms of like the big problems we're trying to solve, one of the huge ones is the underutilization of salvage therapy, especially post-prostatectomy, but also post-radiation. And this slide shows a study we did in the Michigan Urological Surgery Improvement Collaborative, and it looked at the use of salvage radiation post-prostatectomy at practices across the state of Michigan. And the way this graph works is that each of the practices is on the x-axis, and then the rate of salvage radiation for patients with biochemical recurrence is on the y-axis. So each dot represents an individual practice. And you can see there's this huge variation in the utilization of salvage radiation, which really should be given for a patient with biochemical recurrence. And overall, the utilization was low. About 30% of patients getting appropriate salvage radiation in the biochemical recurrence setting. And this is Michigan, but this has been shown in lots of other contexts. So this is a problem we need to address. We also looked in Michigan about how we can improve this. One of the amazing things about the Michigan Urological Surgery Improvement Collaborative is that there's a collaboration with Blue Cross and Blue Shield of Michigan. And so we were able to develop a value-based reimbursement metric. And that the idea was to provide a financial incentive for providing appropriate utilization of salvage radiation, and then also a huge educational initiative. And this is data that's being presented on Monday by Arshad Santosa. Let me see the colors. So the lowest, I guess, blue line is the rate of salvage radiation prior to the value-based reimbursement change, and that went from 2019 to 2021. And then red was actually during that change, the reimbursement period, and then green was after that reimbursement period was over. And it's kind of interesting. So what you see is that tight little window, which corresponded to COVID. It didn't really move the needle much, but we did see a huge change from 2021 on, and it, I think, speaks to both the impact of that financial incentive to some degree, but also education and implementation that take time, but the ultimate impact was that this is something that can change. We also highlighted in the guideline the importance of health equity and disparities in this context. It's really important for this guideline because it's so technology heavy, and we need to think about access and ensuring that access is equitable. And I think an important study to be aware of that speaks to this issue was led by Bob Dess a few years ago. And what the data showed is using the SEER registry, they looked at the hazard ratio for prostate cancer specific mortality according to race. And so hazard ratio above 1 means higher risk of prostate cancer specific mortality among Black compared to white men. And overall, kind of as we often see, there was a higher risk of death in Black men. But when we adjust for key associated variables, it starts to that change is diminished, that increased risk is diminished. And then when we look in equal access care systems like the VA, or we look in patients enrolled in clinical trials, then that difference actually completely evaporates. And so when we address access, then that increased risk of mortality seems to evaporate. So this is important. It's really important to think about in the context of this guideline. Huge credit to Dr. Cameron for leading that development of that section. The last thing that I want to highlight during this portion of my talk is Guideline Statement 5, which deals with prognostic factors in the biochemical recurrence setting, because we spend a lot of time trying to identify which are the data-driven, evidence-based prognostic factors in the biochemical recurrence setting. If you look at the guideline, it says clinicians should use these factors to counsel patients with a detectable PSA about the risk of clinical progression. And these factors pop up in multiple spots of the guideline. And I want to go through these factors because they're really important, and there's a great table that illustrates these. So they are grade group, high grade, stage, surgical margin status. And what's important about surgical margin status is that positive margins are associated with an increased likelihood of biochemical recurrence, but also a lower risk of disease progression after salvage radiation. So that's an important nuance about surgical margin status. Of course, node positive disease, short PSA doubling time, short interval from primary therapy to PSA recurrence. Oops, there we go. Higher post-prostatectomy PSA, genomic classifier risk, and PET imaging findings, all associated with worse prognosis in the setting of biochemical recurrence. And there's great data for all of these in a number of different studies. I wanted to highlight that time difference, the time that it takes from, say, the time that a patient has a delay from surgery to recurrence does have a huge impact on their prognosis. And I think we know this clinically, and this is work led by Dr. Borjan, so that if you look at these curves showing systemic progression over time, patients on that have that short time, less than 1.2 years, to recurrence compared to all the way at the bottom greater than basically 6 years to recurrence. There's a huge difference in the subsequent risk of systemic progression. And there's data, again, for each of these. There's really strong data for genomic classifier risk. And if we look at comparing high genomic risk versus low genomic risk, on the left side, it's risk of distant metastasis. On the right side, it's risk of prostate cancer-specific mortality, with low being the light blue, intermediate being the yellow, and high being the darker blue. We see that spread in risk of subsequent metastasis and death from prostate cancer. So again, each of these is evidence-based, important prognostic factor. Okay, so that kind of sets the stage. And with that, I want to bring up Dr. Borjan again. Thanks, Steve, for going through adjuvant versus salvage and all these other important topics.
Thanks so much. All right, well, good morning. I do want to thank Dr. Morgan both for including me in this course and for his leadership of the guidelines. It's an enormous undertaking, amount of work. He led it really deftly, and we're very grateful for his leadership. I'm going to cover a couple of different topics in the post-prostatectomy space. These are my financial disclosures. They're all in the area of non-muscle invasive bladder cancer, so they're not relevant here. But I do want to acknowledge that a couple of the topics that I'm going to cover are actually part of the clinically localized AUA prostate cancer guideline that was released in 2022, and some of this is actually in between the two guidelines as well. There are really four topics that I want to highlight in the next few minutes. The first is, what is the role of adjuvant versus salvage radiation therapy after prostatectomy? Do a prostatectomy, have adverse pathology, what do you do? The next, which I've purposely added a question mark to, is what is the role of ultrasensitive PSA? We'll talk then about the rationale for what we call early salvage radiation therapy, and then finish up with what should be our imaging or staging evaluation for a patient who has biochemical recurrence. So let's start here, post-op, get our pathology report back, and there are adverse features such as seminal vesicle invasion, extraprostatic extension, or a positive surgical margin. And there's really been a decades-long debate. Should we immediately throw the kitchen sink, use what's called adjuvant radiation, or should we follow this patient's PSA, and then if the patient's PSA begins to rise, use what we would call salvage radiotherapy? I would say we now, in the last 5 to 7 years, have 3 large prospective trials to help inform this question, and those trials then put their data into a meta-analysis, which I'll show you as well. This is the largest of the 3 trials. It's called Radicals. It enrolled almost 1,400 patients, and you can see their adverse pathology features here that were eligibility for enrollment, and it basically randomized them after surgery. Adjuvant radiation versus PSA surveillance with what we would call early salvage radiation at a PSA of 0.1 or higher here. Here's the take-home from the trial. Nearly identical 5-year biochemical recurrence-free survival between the patients who got immediate radiation therapy and those patients who were followed and got radiation if they had a PSA that began to bump up to 0.1. And on the flip side, those who got that early, that adjuvant radiation, had worse urinary continence at 1 year and an increased risk of urethral stricture disease at 2 years. Second trial that was done in Australia and New Zealand, known as RAVES, 333 men. Again, you can see the eligibility criteria here. Once again, randomized to adjuvant radiation, or what we would call early salvage, and here it was 0.2. Follow-up was 6.1 years. Once again, nearly identical 5-year biochemical recurrence-free survival, 86 versus 87%, so not different if you did the radiation in the adjuvant or the early salvage setting. And once again, worse GU toxicity in that very early or adjuvant radiation cohort. Those 2 trials then put their data together with a third trial into what's called the artistic meta-analysis. Over 2,100 men published in Lancet. Take-home message, no evidence that event-free survival is better with adjuvant versus early salvage radiation therapy. And in fact, if you look at the 2022 AUA guidelines, they tell us that we should not routinely recommend adjuvant radiation after radical prostatectomy. So that's really the first take-home point I want to leave you with. But I also want to call attention to the fact that in this statement there is the word we should not routinely recommend adjuvant radiation, because it does leave the question open, is adjuvant radiation therapy absolutely dead? And I think you always need to know letter of the law, what do the guidelines suggest, but then in clinical practice, do those guidelines, do those trials apply to all patients? This was a very nice commentary that was done by Daria Tilke and Anthony D'Amico that scrutinized what patients were actually put into those trials. And what they showed was that only 5% of patients in that largest Radicals trial had lymph node positive disease, less than 20% had Gleason 8 to 10 disease, less than 20% had seminal vesicle invasion. So it leaves the question still, in the absolute highest risk patients, do we for sure know that adjuvant radiation therapy is not effective? And those investigators then went on to do this study, which is a retrospective analysis and can't take the place of prospective randomized trials, but I want to show it to you because I do think it's hypothesis generating, because they looked at what we would call the highest risk patients, those who either had positive nodes or extraprostatic and high-grade disease, Gleason 8 to 10 and seminal vesicle or T3. And they looked at the cohort who got adjuvant radiation, who got even what we would call early salvage, and then who got no radiation. They had over 8 years of follow-up. The outcome that they used here was all-cause mortality, and this is the way the numbers kind of broke down in their cohort series. And what they found is that if a patient met the criteria of adverse pathology, which here is node positive or high-grade and extraprostatic, those who got adjuvant radiation were associated with a lower risk of all-cause mortality. For those patients who didn't meet this pretty strict bar of adverse pathology, using adjuvant radiation was not associated with a decreased risk of all-cause mortality. Nicely illustrated, I think, in the table here. You can see in the top box that I've put in red, those who met the criteria of adverse pathology had a significant decrease in all-cause mortality with adjuvant radiation. And then I've put each of the 3 randomized trials in a different color. And what you can see is that for the patients in their series who would have met trial eligibility criteria, adjuvant radiation was not associated with all-cause mortality, basically indirectly saying that the patients in those trials were a lower risk cohort. So again, I think you should know the guidelines. Don't routinely use adjuvant radiation. I think in the future here, is there a potential in higher risk patients, TBD. So let's now move to biochemical recurrence. And again, I think it's important to know what is the letter of law guidelines, and then how do we apply those guidelines to the patients we're going to see in practice next week. So what do the AUA guidelines tell us about the definition of biochemical recurrence after radical prostatectomy? PSA greater than or equal to 0.2 with a second confirmatory value greater than or equal to 0.2. Now, with that said, I think we all would understand that not every patient with a detectable PSA after surgery is at the same risk for subsequently developing metastatic disease. And with that concept in mind, several groups have looked at the concept of whether or not we can apply a risk-stratified definition of biochemical recurrence. This is one study that was done at Cleveland Clinic, which took 14 different definitions of biochemical recurrence and correlated them with patients' disease risk as estimated by a nomogram 5-year prediction of progression-free survival. They generated these curves, but really what they showed is that if a patient had a nomogram 5-year progression-free survival less than 50%, indicating high-risk disease, the best definition of biochemical recurrence was actually 1 PSA greater than or equal to 0.05. On the flip side, if a patient had a nomogram 5-year progression-free survival prediction greater than 90%, indicating that that patient has low-risk disease features, the best definition of biochemical recurrence is greater than or equal to 0.4 and rising. So take-home point here really is that we may use a lower threshold to define, and as we're going to talk about, to treat patients with biochemical recurrence depending on their disease risk, especially with high-risk features. This was a nice study led by Dr. Morgan and colleagues, over 3,500 patients who underwent surgery with a follow-up of over 3 years. Instead of nomogram, here they used Capra score to stratify patients' disease risk as low, intermediate, and high. Very similarly, they applied a risk-adjusted definition of biochemical recurrence greater than or equal to 0.05 for low-risk patients, greater than or equal to 0.5 for high-risk patients, greater than or equal to 0.4 for low-risk patients, and they found that applying that risk-stratified definition had the best performance characteristics in terms of positive predictive value. So really, again, I would say second take-home point, know the AUA definition, but understand that patients' disease risk needs to modify that when we're treating patients in clinic. Now let's move to the second topic. How might we do what I would call early detection of biochemical recurrence? And this is the concept of using ultrasensitive PSAs. Ultrasensitive PSAs are assays that can detect PSA levels less than 0.1. What do the guidelines tell us? The guidelines tell us that we may use an ultrasensitive PSA assay in a patient for whom we would be considering salvage radiation therapy. Why? We have some older data out of NYU that have shown us that those patients who have a higher ultrasensitive PSA value are at increased risk to subsequently then develop what we would call formal biochemical recurrence. But I think before we start going out and ordering a whole bunch of ultrasensitive PSAs, we also have to carefully scrutinize the number of questions that exist. First, we don't have prospective trials telling us that using ultrasensitive PSAs to direct therapy actually benefits patients. Second, we don't have an established and validated cut point for an ultrasensitive PSA that would say it's at this threshold that we should or shouldn't institute therapy. And when we're talking about PSA levels really at that low level, we're looking at the potential of detecting what we would all call indolent recurrence, something that's never likely to cause a patient significant harm, or even detecting the presence of microscopic benign prostate tissue. And with that in mind, the guidelines also include this important caveat statement, that if you have an ultrasensitive PSA detection, don't act on that. Confirm a rising trend before instituting secondary therapy. So don't act on a single ultrasensitive PSA value. Second take-home point here. Okay, now let's move to the concept of salvage therapy for patients with biochemical recurrence. An important question to ask when we're thinking about salvage therapy is whether or not instituting treatment can actually impact what we understand and what Dr. Morgan was teaching us about the natural history of biochemical recurrence. So we have several observational cohort studies that have analyzed that question of whether salvage therapy can impact the natural history of biochemical recurrence. These are data from Johns Hopkins, 635 men who had biochemical recurrence, of whom 238 got salvage radiation. They had a follow-up of 9 years after surgery and 6 years after recurrence, and what they found was that among men with biochemical recurrence, those who got salvage radiation had significantly better cancer-specific and overall survival. Retrospective data, but intriguing and hypothesis generating that perhaps we can interrupt the natural history. Second study, led by Daria Tilke and colleagues from Europe, looked at over 1,800 men with biochemical recurrence, of whom approximately 1/3 got salvage radiation. They had long-term follow-up. They used a statistical modeling known as propensity score matching to adjust for the confounders that would be inherent to such a retrospective study design. And what they showed was that among men with biochemical recurrence, those who received salvage radiation, significantly better metastasis-free survival, significantly better overall survival, results maintained on multivariable analysis. Again, a hint of signal here that using salvage therapy may interrupt that natural history. And that really does bring us to the 2024 guidelines released. And we call this early salvage. Why? Because guideline statement number 1 from these recently released guidelines states that we should be informing our patients that salvage radiation is most effective when given at lower levels of PSA. Now here again, we have several different series that have helped provide the data to support that statement. This is a multi-center experience of almost 2,500 patients treated with salvage radiation and followed for 5 years. And what they found was that if you got salvage radiation when your PSA was less than 0.2, super early salvage radiation, your subsequent 5-year biochemical recurrence-free survival was actually over 70%. If you got your salvage radiation when your PSA was between 0.2 and 0.5, that dropped to 63%. And then you can see as your PSA gets higher when you get salvage radiation, your subsequent 5-year biochemical recurrence-free survival goes down. A study that looked at this from the flip side, which is what's the cumulative incidence of biochemical recurrence. Okay, in over 1,100 patients treated with salvage radiation at 10 centers and followed for over 5 years, found that the cumulative incidence of biochemical recurrence is higher the higher your PSA when you get your salvage radiation. So if you're getting your salvage radiation with your PSA less than 0.2, your subsequent 5-year biochemical recurrence-free survival, your subsequent 5-year biochemical recurrence is only 26%, but it significantly goes up as your PSA goes up. We're going to get a theme here. Over 1,100 patients, again, this is from our radiation oncology group at Mayo Clinic, followed for 9 years. They looked at a pre-salvage radiotherapy PSA cut point of 0.5 as a prognostic factor, and what they showed was that if you got your salvage radiation with your PSA less than or equal to 0.5, you had significantly lower risks of secondary biochemical recurrence, significantly lower risks of developing distant metastatic disease, and significantly lower risks of death from prostate cancer. Data from Europe in over 1,000 patients here, again, using that 0.5 prognostic cut point, follow-up over 5 years, multivariable analysis, early salvage radiation, significantly lower risks of metastatic progression and death from prostate cancer. And finally, a study of over 25,000 men treated with radical prostatectomy, follow-up 6 years, looking at all-cause mortality, breakdown, as you can see here, in distribution of patients. They looked at a variety of different cut points going all the way down to 0.25. And at each of these thresholds, early salvage radiation, lower risk of all-cause mortality. On the flip side, below 0.25, no significant difference in all-cause mortality. So when you look at the curves here, this is a graphical way of presenting what I just showed you. Getting salvage radiation therapy with a PSA less than 0.25, significantly lower risks of subsequent all-cause mortality. Guideline statements 2 and 3. What should we do? We should administer salvage radiation therapy with a PSA less than 0.5, and for patients with high-risk features, we may offer it at a PSA less than 0.2 based on the data that I just showed you. Let's finish with just a few words about imaging, or how should we stage patients who have biochemical recurrence. Several different terms that we commonly hear. Conventional imaging, that really means bone scan, CT, MRI, and then there's a number of different terms, molecular imaging, next-generation imaging, and for all intents and purposes now, that means PSMA PET. What's the data to support PSMA PET for patients with biochemical recurrence? This is a series of over 600 patients with biochemical recurrence after either surgery or radiation that had their imaging with a PSA of 2.1. The reference standard was sort of a composite endpoint of confirmation imaging biopsy. Positive predictive value of the scan was 0.92. And very importantly, they showed that the detection rate of PSMA PET directly correlates with the PSA at the time the scan is gotten. So you can see the higher your PSA when you get a PSMA PET, the more likely the PET is to be positive. Nevertheless, even in the range that we're talking about early salvage radiation, PSA less than 0.5, between 35 and 40% of PSMA PET scans are positive, suggesting that even in that cohort, it has value. This is what's known as the CONDOR Phase 3 multicenter trial, 208 patients with biochemical recurrence, again, after either surgery or radiation. Here, median PSA is even lower at 0.8. Patients had negative or equivocal conventional imaging. Very similar sort of reference composite standard. Correct localization rate, 85% among 3 readers. 64% of patients had a change in their management plan based on the PSMA PET results, demonstrating that this can impact how we manage patients with biochemical recurrence, once again showing that the detection rate of PSMA PET directly correlates with the PSA level when you get the scan, but also once again showing that even at the lowest levels of PSA, less than 0.5, 35 to 40% of patients will have a positive PSMA PET scan. And we had a little discussion on this yesterday during the plenary session. This is an ongoing Phase 3 randomized trial that's looking at patients who experience biochemical recurrence after surgery and randomizing them into 2 arms: immediate salvage radiation for your biochemical recurrence, or get a PSMA PET, interpret the results, and then maybe salvage radiation depending on the results of the PSMA PET scan. This is in a cohort that we would call early salvage radiation, less than 0.5. The primary endpoint is going to be 5-year biochemical recurrence-free survival, and that's ongoing. But what the trial reported in interim results was that almost half of the patients in the PSMA PET arm had a change in their management plan based on the findings from the scan, and the vast majority were from the scan itself. So, what do the guidelines tell us about imaging for patients? In patients with biochemical recurrence, we may obtain a PSMA PET scan. For patients with biochemical recurrence in whom we are considering salvage radiation therapy, we should perform next-generation imaging. Why? Because we want to exclude patients who have extrapelvic or distant metastatic disease from local salvage radiation. But I also want to emphasize the flip side of this, which is that we need to be very, very careful about how we use a negative PSMA PET scan in a patient with biochemical recurrence. Really absolutely critical point from this talk here is that in a patient with biochemical recurrence who has a negative PSMA PET scan, we should not withhold salvage radiation therapy. Why? Because the detection rate is simply not high enough to detect microscopic residual disease that still may be effectively treated with salvage radiation. Is there any role for conventional imaging now in the PSMA PET era? The guidelines state that we may also obtain a pelvic MRI. Why? Because of the potential to enhance detection of prostate bed recurrence and modify treatment accordingly. So what do I want to leave you with here in conclusion? First, our data tell us collectively adjuvant radiation not better than PSA surveillance with early salvage, and you're going to spare a whole lot of patients from needing secondary radiation with that approach. So don't routinely use adjuvant radiation. May obtain an ultrasensitive PSA after surgery, but don't act on a single ultrasensitive PSA value and confirm a rising trend before treatment. Staging patients with biochemical recurrence, yes, use a PSMA PET scan if you're considering salvage radiation, but don't withhold the radiation if the scan is negative. What do we call early salvage radiation? The concept is really to treat at lower levels of PSA, so we should do it before 0.5. We may even do it less than 0.2. The key really is, again, to consider in the context of both patient and disease risk. So with that, I'm going to stop, and thank you very much for the opportunity to join you this morning. Sure. So I think we have a time for questions? Yeah, perfect. I don't know if there's questions, we can do them now. We can come, if we can come up to the microphone, because I think we're recording this, so we can have people. Sure.
Hi, nice talk. A question, a lot of times, especially someone that needs early adjuvant therapy who has, very aggressive type prostate cancer, as you pointed out, some of those patients still don't have urinary control, and you're concerned about how that may impact, their long-term control. And can you comment about the role of hormonal therapy, which a lot of those patients also need when they get radiated, and delaying the radiation until they have better control?
Yeah, really good question. That's one of the most common clinical situations that we all struggle with. The intersection of pulling the trigger on a patient with high-risk disease for secondary therapy while they regain functional outcomes. I would say that this is a situation in which we individualize it a little bit. If they have lymph, and we're going to hear about the role of hormone therapy in patients with salvage radiation as part of this. But I'll tell you what we do here. In a patient like that, if they have lymph node positive disease really specifically, we will start them on ADT while they are recovering their functional outcomes. And then usually at about 6 months or so, use secondary radiotherapy in somebody like that. So that's how, particularly high-risk features where there's lymph node positive disease, and you are recognizing that this is a patient that's going to need multimodal therapy, but you don't want to use early radiation because of some of the data I showed you, and it's been reproduced elsewhere, that early radiation therapy after surgery does negatively impact urinary outcomes. I think it's a very sensible strategy to start them on the hormone therapy that they are going to get anyway, as we'll hear about, with their radiation. That is early disease control as well, and then add the local therapy when they've recovered their functional outcomes.
Yeah, this is a patient I've really struggled with. He's now 46. He had grade group 3 cancer that was resected 2 years ago, focal positive surgical margin, extraprostatic extension. PSA has been 0.04, 0.04, 0.05. What's kind of a good trigger for this guy? I'm trying to hold off as long as possible on salvage therapy on him, but he's so young that I have to try to consider a lot of different things.
Well, so I think I'm happy to take. Okay. So some of it depends a little bit about nodal status, I would say. And you're how far from surgery?
2 years.
2 years. So if you're 2 years from surgery with a PSA that's stable at 0.0405, I don't think that you are missing any kind of a window personally by continuing to do surveillance on that patient. I really don't. I mean, I think, one of the data points that Dr. Morgan presented was time from surgery to biochemical recurrence. And in the paper that he showed you from Mayo, biochemical recurrence was actually defined at 0.4. So it's an older data set. So you're, 10-fold less than that. I actually think, personally, if you said, what would I do 2 years out, I'd keep watching him.
Yeah, is this on? Yeah, I totally agree. That's a great question, a great point. That's, that really speaks to the use of ultrasensitive PSA, and it can really steer us probably awry in that setting. That we're 2 years out, the patient's doing really well. 0.05, that sounds really good. And so, for that kind of patient, I'm waiting until their PSA hits at least 0.1. Awesome. Thank you. Oh, we have one more. Yeah, we got time for one more. Let's do it. Yep.
There was a discussion a bit earlier, or allusion to withholding salvage radiation in the case of extrapelvic positivity on the PET scan. But in the era where, particularly for younger patients, they're being very aggressively treated, even though they have even if they have systemic disease with irradiation and ADT and other avenues, is that an absolute in your mind, withholding salvage if there's extra pelvic disease on PET?
We have
We're
some-
going to get to that.
Yeah.
Yeah, so that's a good prelude. So thanks again, Dr. Borgen. Next, we'll bring up Dr. Cameron, and I forgot to mention, she's very graciously here despite coming down with laryngitis that she's gradually recovering from, but saved me from pretending to be a radiation oncologist. So thank you.
Okay. Thank you, everyone, for the invitation. Sorry. So please bear with me. I'm recovering from laryngitis. Let's see. So I'm very excited to be here. Here we go. These are my disclosures. Nothing relevant. So what I'm going to talk about today is I'm going to just go over the approach to salvage radiation therapy, post-radical prostatectomy. I'm going to talk a little bit about the radiation field and then the management of pelvic lymph nodes, which is something that everybody's always wondering about. I'm then going to talk briefly about the management of regional recurrence with radiation, and then metastasis-directed therapy with radiation, which is relevant to the question that just came up. So I just want to briefly go over the traditional post-op radiation field when we're just focusing on the prostatic fossa. So as you can see, this is just a nice schematic that picks out some of the areas of focus where we want to cover any seminal vesicles that may be remnants post-surgery. We always want to cover any clips that were left post-surgery. And then on the sagittal image, you can kind of see what the prostate bed radiation field looks like. It kind of looks like a toilet seat that's a little bit up, but that's just the traditional prostatic fossa bed to keep in mind. So salvage radiation, we do know, is important to offer, as you heard from earlier, but it is associated with negative impacts on urinary, bowel, and sexual outcomes, both acutely and long-term. Although we do know adjuvant radiation therapy is worse in those respects. The data are ultimately mixed, but it likely has to do with technique, technology available, timing of therapy, the addition of systemic therapy, etc. A prospective study out of Norway of 120 patients found worsening in all 5 EPIC 26 domains of urinary incontinence, irritative function, bowel, sexual function, and hormonal function. But then there was a study from the University of Chicago of almost 200 patients that found no clinically meaningful worsening in long-term quality of life in any of those domains. So as you can see, the data is extremely mixed. So overall, what this shows us is that we need to have a discussion regarding risk-benefit ratio and participate in shared decision-making with the patients. And that leads us to this guideline recommendation that clinicians should inform patients that salvage radiation poses inherent risks to these to urinary control, erectile function, and bowel function, but we need to consider these risks in the context of the patient and the risks posed by recurrent cancer. So we did hear, again, briefly about the novel molecular imaging, and so should findings be incorporated into the radiation plan? And we know that, again, novel PET radiotracers have allowed for improved detection of recurrent prostate cancer in patients with rising PSA. An older, less sensitive study known as flucyclovine PET has been evaluated pretty extensively, although we now know we use PSMA PET, but we do have a lot of data for flucyclovine PET. This is a radiolabeled amino acid analog, and it takes advantage of the amino acid transport upregulation in many types of cancer cells. It's taken up to a greater extent in prostate cancer cells than in surrounding normal tissue. And we have shown that it has improved detection compared to conventional imaging. This is a study, just a different study that was shown earlier that looks at conventional imaging positivity rates versus flucyclovine PET positivity rates, and you can see based on PSA levels, you can see that flucyclovine PET has improved detection. And then this is again just highlighting with a PSA level of less than or equal to 1, you can have dramatically improved detection levels with the flucyclovine PET compared to conventional imaging, and that is statistically significant. So now, how does this play a role into management decisions? So this was a nice study looking at whether or not it changed radiation planning. So this was 165 patients with detectable PSA post-prostatectomy. They were randomized to conventional imaging versus conventional imaging plus PET This again was flucyclovine PET, so a little less sensitive before planned radiation. The median PSA at PET was about 0.33, so again, a modern cohort. And you can see here that the field change was approximately 32% in patients. That on the left-hand side, you can see what the physicians planned for the radiation field before the PET CT, and then you can see what they planned for after they received the PET CT. So you can see about 32% had a decision change. Now, but the question is okay, great, we had this decision change. Does it actually matter clinically if you're changing the radiation fields? And I'd like to point to the Empire 1 study, which again utilizes flucyclovine PET, which is again less sensitive than PSMA PET, but still allows us to get a little bit of insight into guidance for radiation field changes and then whether or not it impacts clinical outcomes. So again, in this study, they had they randomized patients to conventional imaging versus the flucyclovine PET. And in terms of the management change, about 35.4% of patients had a decision change in terms of the radiotherapy field. They then looked at event-free survival, which is on the left-hand side. And you can see that in patients that had the flucyclovine PET, they had improvements in event-free survival that was statistically significant at 36 months post-treatment and even more significant at 48 months post-treatment. So we can say more definitively that this does matter by incorporating novel molecular imaging. So that led us to the statement that the clinician should incorporate treatment of these positive findings into the radiation plan because there is an improvement in clinical outcomes for these patients. And then just as we heard from Dr. Bourgian before, we have to be cautious, and clinicians should not withhold prostate or salvage prostate PET radiation in the setting of a negative PET CT for all the reasons that he outlined earlier. But basically, again, there's false negatives with low levels of PSA. Specifically for PSMA PET, there's non-PSMA expressing prostate cancers, and there's also heterogeneity of PSMA positive cells, and microscopic disease may still be present. So we do not want to wait until the PET scan is positive. We want to offer early salvage radiation therapy at lower levels of PSA detection. So what about if we do not have novel molecular imaging? How should we approach the pelvis? Do we always need to have novel molecular imaging? And we do have data from this. We have excellent data. So I'm going to talk briefly about the NRG RTOG 0534 SPORT trial. This was done in the era without any novel molecular imaging. So this was all conventional imaging. And they randomized patients who were planned for salvage radiation treatment to 3 arms. So prostate PET alone, prostate PET plus short-term ADT, and then prostate PET, short-term ADT, and then pelvic lymph node irradiation. And just as at the bottom, you can see comparing arm 3 to arm 1. So basically, maximal therapy to just prostate PET alone. There was improvement in prostate cancer death, freedom from progression, and distant mets. At this time, there's not improvement specifically in overall survival, but it is trending that way. We probably need a little bit more follow-up, long-term follow-up. And then we can say that this is a modern cohort because patients were enrolled with a PSA less than 1. Well, the majority of patients were enrolled with a PSA less than 1. I just want to point out these curves, the freedom from progression and then the distant metastasis, specifically looking at group 3 versus group 2. So as a reminder, group 3 was maximal therapy, adding the pelvic lymph node irradiation, versus group 2 was just bed plus ADT. And we can see that there was an improvement compared from group 3 to group 2 for freedom from progression and distant metastases. And this is just looking more specifically between group 3 and group 1. So group 1 is just bed alone without ADT and no pelvic lymph node irradiation. And you can see that there was improvements when you actually stratified patients by all these characteristics on the left-hand side. The p-value was statistically significant. So basically, maximal therapy was better than just bed alone. And then this is with regards to freedom from progression. Now, when looking at group 3 versus group 2, more specifically, again, adding lymph node irradiation. Based on these factors, the 2 things I want to point out are there wasn't anything strikingly significant, but this isn't going forward right now. Let's see.
Frozen, I guess.
I think it's frozen.
Is able to advance.
There we go. Sorry. Okay. I just want to point out that for patients at a PSA between 0.1 and 1, there was a trend towards statistical significance when adding lymph node irradiation, but that was not the case when the PSA was greater than 1. So obviously, this is just hypothesis generating, but something to keep in mind. So that led to this guideline statement that clinicians may use expanded radiation fields to include the regional lymph nodes for patients that are presenting for, that you're considering for salvage radiation treatment. So how do we implement this in practice? I just wanted to briefly show that this is the NRG Oncology Consensus Atlas that was published in 2021. We now include the radiation field to start at L5S1, and we want to include the common iliac artery and vein, and we bring it down, and it ends around approximately the bottom of S3. So just something to keep in mind when you talk to your radiation oncologist, this is what we're treating. Now, what about toxicities? If you're adding the pelvic field, do you have increased toxicities? So what was found when you're comparing adding pelvic lymph node irradiation to group 2, which again is just bed plus ADT, there was a significant difference with more adverse effects, especially acutely, when adding pelvic lymph node irradiation. GI adverse events, the largest event difference between the groups was related to diarrhea. And then for blood and bone marrow events, the difference was related to lymphopenia. However, late toxicities were not different with the addition of pelvic lymph node radiation to ADT, like overall late toxicities compared to prostate bed RT alone. So that's just something else to keep in mind. So it was generally well tolerated, but something to definitely counsel your patients on. So basically this just says, that guideline statement says that if you are going to include regional lymph nodes, this may increase the risk of side effects, particularly in the short term compared to prostate bed RT alone. However, toxicities may be further reduced with the use of modern radiation techniques. So that's something that's coming down the pipeline. Now, what about management of regional recurrence? So we're seeing this more often. So this is just an example on the left-hand side. Let's say you get a PSMA PET scan and you see an isolated nodal recurrence post-prostatectomy. What do? This is an increasingly common clinical scenario. So we don't have a lot of data to guide us specifically for this scenario. However, I'm going to talk about the oligopelvis Chatuk study. This was a single-arm phase 2 trial that enrolled men with 5 or fewer pelvic lymph nodes detected using PET imaging. They were treated with Salvage comprehensive nodal RT plus 6 months of ADT, and patients received prostate bed RT as well if that was not previously treated. The primary endpoint was 2-year progression-free survival. And overall, they had 67 patients enrolled. Patients could have had a prior radical prostatectomy or a prior prostatic radiation. Only 6 patients fit that criteria. Median follow-up was almost 50 months. And you can see the 2-year progression-free survival was pretty excellent. It was over 80%. 3-year was about 58%. And then just other things to point out, the 2-year biochemical relapse-free survival was 58%. And 3-year was 46%. And then in terms of toxicity rates, grade 2 or higher, GU and GI toxicity rates, 2 years was 10 and 2% respectively. So it was generally well tolerated, so it can be offered to patients. And then we're gonna find out more information from the PEACE 5 STORM trial, which is ongoing. So this is enrolling patients with oligorecurrent PET-detected pelvic nodal prostate cancer. They're stratifying by the PET tracer that was used to identify these patients, as well as the type of metastasis-directed therapy. They're randomizing patients to Arm A, which is metastasis-directed therapy, which could consist of SBRT or salvage lymph node dissection plus 6 months of ADT, versus MTD plus whole pelvic radiation plus 6 months of ADT. So this data is coming, and we should get some more information on how to guide us with these clinical scenarios. But for now, in our guideline, what we said is that clinicians should offer ADT plus salvage radiation to the prostate bed and pelvic lymph nodes at this point in time if there is a detectable pelvic node recurrence following primary radical prostatectomy. Now, the question comes up, what if prior pelvic radiation was not given in a patient who has a pelvic nodal recurrence detected on novel molecular imaging following primary prostate radiation? So let's say a patient was low risk or intermediate risk and just received prostate-directed radiation, and then years later they have a biochemical recurrence, they get a novel PET scan, and you're seeing a node. What do? So again, there's a dearth of data in this space, and we only have 6 patients that met this criteria in the oligopelvis trial. However, for those 6 patients, it appeared to be favorable for disease control, and again, it was generally well tolerated, but again, only 6 patients in that trial. So we feel like it's reasonable to offer both pelvic nodal radiation and ADT for potential of long-term disease control with salvage radiation compared to just doing ADT alone. And in this case, we can if you have the prior radiation fields, you can carefully match the radiation fields and add on a whole pelvic radiation field safely and effectively to treat this scenario. Now, in the scenario, like let's say a patient was high risk and they ended up having pelvic nodes radiated at the same time as their primary prostate radiation, it's unclear whether reirradiation may be of benefit if there's a pelvic node that shows up right in the prior radiation field. You could consider more focal options such as SBRT or salvage lymph node detection, but these do come with increased toxicity. So this is something that you would need to carefully counsel your patients on. But in our guideline, for this particular scenario, in patients who did not receive prior pelvic nodal radiation, we state that clinicians should offer salvage pelvic nodal radiation plus ADT. And then finally, I just want to end with metastasis-directed therapy, specifically oligometastatic disease. So in 1995, 2 radiation oncologists, Dr. Hellman and Dr. Weichelbaum, introduced the oligometastatic concept. They essentially described a state of metastases that may be responsive to localized curative therapeutic strategy. Previously, we have been limited by the ability to really accurately image metastases, and we would only, with conventional imaging, be able to capture patients once they're widely metastatic. However, with improved imaging, we're now able to capture patients that only have a few metastases. And so this concept is now being tested in large controlled trials. Now, what about oligometastatic disease and prostate cancer? So just some numbers, under 5% of prostate cancer patients present with metastatic disease, but this can be higher, as high as 20% in patients populations without screening. So of that 5%, oligometastatic disease represents a portion of these patients. And it is known that if you have local regional metastasis, that confers a survival benefit compared to widespread metastases. Now, the definition of oligometastatic disease varies widely, and no one has been able to agree on this definition, particularly in the era of novel molecular imaging. A lot of people like to use the charted definition. This is probably the most common in ongoing studies, which defines high volume disease as greater than or equal to 4 bone mets, including one or more outside the vertebral column or pelvis and or visceral metastasis. But we don't really know what the right definition is. What our guidelines say is that clinicians may perform stereotactic ablative radiotherapy, also known as SABR or SBRT, metastasis-directed therapy, to patients that meet the oligometastatic criteria, but should consider the risk of toxicity versus benefits. Now, where does the data come from for that? So right now we don't have any phase 3 trials, but we do have some excellent phase 2 trials that I'm going to briefly discuss. We have STOMP, ORIOL, and the EXTEND phase 2 trials. So first, the STOMP trial, which was published in 2018. This was a randomized trial, multi-center. It was small, 62 patients, randomized 1-to-1 to either surveillance, and just a note, surveillance included just observation. They did not get any ADT, which is one of the limitations of this study, or MTD to all lesions, and it could be surgery or SBRT. Their definition for oligometastatic disease is listed there, and the median follow-up was 3 years. You can see what patients received for MTD. And they looked at ADT for free survival, and you can see with the intention to treat analysis as well as the per protocol analysis, it wasn't quite statistically significant between the two, but there is, you can see that there is a clear benefit towards ADT survival in the MTD group. But again, there's some limitations. Obviously, the sample size is very small. One of the biggest limitations is that the control arm was surveillance only. There was no ADT offered, and they used, again, choline PET, not PSMA PET. So we'd have to repeat these analyses in an era using PSMA PET. But, it's also very thought-provoking. MTD may improve ADT-free survival. So this is just an analysis looking at patients, different characteristics that they stratified patients by, again, intention to treat on the left, per protocol on the right. And more specifically, if patients had a PSA doubling time that was less than 3 months, there was a strong favoring of metastasis-directed therapy in terms of ADT-free survival in both the intention to treat and per protocol analysis. So that's, again, something to consider for patients that present with MTD, or with oligometastatic disease, sorry. Next, I'll just briefly talk about the Oriole trial. Again, multi-center, randomized phase 2. You can see the eligibility criteria listed there. Again, a small trial, 54 patients. All patients, interestingly, underwent a PSMA PET, but the results were blinded to investigators, and I'll talk about why that's important in the next slide. But they were randomized 1-2 to observation. Again, no ADT or SBRT to all lesions on conventional imaging. The SBRT fractionation is listed below. And they looked at progression-free survival, and the median follow-up was almost 20 months. And you can see that there was a benefit to SABR of all the lesions in this particular cohort of patients, and that was statistically significant. And then later, they looked at the patients, the 36 patients that were treated with SBRT who had a PSMA PET, and they wanted to see if they missed any lesions that weren't treated by SABR because they didn't appear on conventional imaging. And what they found was that treating all PSMA visible lesions was associated with improved progression-free survival and distant metastasis-free survival. So of the 36 patients treated with SBRT, about 16 had baseline PSMA PET avid lesions that were not treated. But this, again, it's hypothesis generating because this was a post hoc analysis, but it suggests that we should be treating all lesions that we see, especially with novel molecular imaging. But again, the caveat with these two trials is that the control arm it's just surveillance, it's no ADT. So we don't know if MTD is beneficial in the presence of ADT. And so we do have some early data hinting at this from the Extend trial. This was published just recently last year. Phase 2 trial, multi-center, 87 patients randomized 1-to-1, and they were randomized to hormone therapy versus hormone therapy plus definitive radiation to the metastatic sites. And you can see, again, their inclusion criteria for oligometastatic disease, a little bit different than the prior ones. And then on the right-hand side, you can see listed what the SBRT delivery was. And so these are just the summary results. They looked at progression-free survival. And on the left-hand side, you can see they looked at progression-free survival by randomization arm, and there was an improvement in progression-free survival in the combined therapy arm. So adding SBRT to ADT was significant for progression-free survival. They also looked at eugonadal progression-free survival. So when patients recovered the testosterone, they also saw that there was still a significant benefit to the combined therapy arm. And then just some hypothesis-generating information. They looked at they stratified patients by the number of metastatic lesions. You can see that there was a larger benefit in patients that had 1-2 mets versus more 3-5. And then they also looked at patients that received second-generation anti-androgens because that was allowed on the trial. And there was a bigger benefit in patients who received, standard ADT plus the addition of a second-generation anti-androgen. Again, this is just hypothesis generating, and the overall survival data is immature at this time. And we're very excited for the ongoing phase 3 trials. These are just listed here. You can see there's many of them. And in general, they all have the definition of oligometastatic disease as being about 5 mets, but their screening imaging is different. But we're looking forward to the results from these. So conclusions, salvage postoperative radiation may be associated with both acute and late toxicities. So we need to counsel our patients on this. However, we know adjuvant radiation is worse, and the benefit of salvage radiation must be weighed against risks, and shared decision-making is crucial. The introduction of novel molecular imaging may change post-op radiation field, but the change in field does appear to matter clinically, so it's important to incorporate these findings. The Empire 2 study is ongoing, and that's actually going to evaluate PSMA PET versus flucyclovine. As a reminder, the Empire 1 study included flucyclovine, so this is what we're really looking forward to seeing. And it's also going to look at dose escalation to areas of PET uptake, because right now they didn't change the dose in Empire 1. They just did standard dose. They just changed the field size. And then a negative PET should not preclude patients from receiving salvage XRT. That's really critical to keep in mind. Even without molecular imaging, we have good data to show that clinicians may consider expanding post-op XRT fields to include the pelvic lymph nodes. Appropriate counseling on the potential for increased toxicities is important because there's a larger XRT field at this time. And in the setting of an isolated nodal recurrence on imaging post-primary therapy, data suggests that the addition of salvage XRT to the bed plus lymph nodes in addition to ADT is beneficial. And there's really a dearth of data in the space where the prostate was previously irradiated, but you could consider offering pelvic nodal radiation plus ADT. And you really need to be cautious in patients who received prior pelvic lymph node irradiation who's showing up with a positive lymph node again. And then, of course, metastasis-directed radiation therapy should be offered to patients who are motivated to achieve time off systemic therapy, particularly. And phase 3 trials are underway to truly understand the definitive oncologic benefit to MTD, particularly in the presence of systemic therapy. So with that, I just want to say thank you, and thank you for allowing me to be a part of this guideline and present today. And I apologize for my recovering laryngitis.
Thanks. That was an amazing talk. Heroic effort. Laryngitis sucks, so that was incredible for you to do that. But the talk was phenomenal. We have a couple minutes if there are questions. Okay. Short of that, we'll keep going. Dr. Tagawa is going to give us the landscape of systemic therapy in this setting. Thanks a ton, Scott.
All right. Thanks, Todd, for the invitation. So these are my disclosures. Leave it up for a minute. They're online. So in one slide, this is what you have. You can read it all. But these are the parts of the current guideline that involve systemic therapy. So I'm going to walk you through each one. So, and I can't explain. At least one of them was one of the questions that you may be asked again. So what I'm going to do is I'm going to go through the individual guidelines and then show you some of the data. I'm going to include the data, and if you read the full guideline, you'll see the references with some comments about why some of the guidelines are written like that. AUA guidelines, like most other evidence-based guidelines, when there's only preliminary data in abstract form, they don't come into the guidelines waiting for the peer-reviewed literature, but as I'm giving a talk, I'm going to be able to show you some of the abstract data. So anyway, just to kind of go through that. So ADT should be added to salvage radiation is kind of the bottom line. And there's the high-risk features. I'll bring up the table that Todd already showed again in a second. But these are based on 3 primary studies walking through. So the JETUG study was salvage radiation with 6 months of LHRH versus radiation alone. And you can see the entry criteria. They use their own risk factors as one of the stratifications. This is all published. 2 main initial publication, and another updated publication. And then it was pelvic bed and then pelvic radiation if there was not a lymph node dissection. The primary endpoint was biochemical and a clear benefit in terms of biochemical, but later there was also an MFS benefit, as you can see in the kind of the bottom to the right curves there. So evidence that 6 months of ADT in addition to salvage radiation is of some benefit both in terms of PSA as well as MFS. R2G 9601, so many of our cooperative studies will have the year in them, so you can see when this was initiated a while. Salvage radiation alone or salvage radiation plus 2 years of hormonal therapy. The 2 years of hormonal therapy was high-dose bioclutamide, so no longer on the market. You can obviously prescribe it if you want to give 3 pills, but was being used at that particular time. Preoperative ADT was allowed as a kind of a minor comment, and as we talk about toxicity, there was not gynecomastia prophylaxis. And this one, published the primary publication many years later, top left corner, an overall survival benefit. This is why this was in the New England Journal. Evidence for 2 years of hormonal therapy, although in this particular trial, 2 years of hormonal therapy was 150 milligrams of biclutamide. This trial is already discussed. What I'm going to focus on are the 2 arms. So what was discussed initially was prostate bed versus prostate bed plus pelvis radiation. The other part of the randomization was ADT yes or no. In this case, ADT yes or no included 4 to 6 months. So one of the reasons 4 to 6 months is embedded into the guideline is because it was 4 to 6 months in this particular trial. And these curves were already shown, so just red is the control. So the other two arms, the green and the blue, included ADT, short-term ADT, 4 to 6 months, and that was better, whether or not the patient received radiation to the pelvis or just the prostate bed. So evidence that 4 to 6 months of ADT, this particular trial used LHRH plus I can't remember if it was specifically bicalutamide, but a first-generation non-steroidal anti-androgen, 4 to 6 months is of benefit. That being said, do we have to give, from a guideline perspective, hormonal therapy when we are administering salvage radiation? Of course, in an individual patient, you do what you want to do. You can follow the guidelines and use evidence, but so many of the guidelines are very specifically say shared decision-making. I think we do that in practice. But we do know, based upon analyses of, retrospective analyses of the prospective trials, as well as large data sets, that there's some people that are cured with salvage radiation. We also know that hormonal therapy, speaking as a medical oncologist who specializes in systemic therapy, we know that systemic therapy, including hormonal therapy, whether it's an anti-androgen alone or LHRH, can have some toxicity. So the table on the right is the table that Todd showed before, are the high-risk features. So patients that are absent of those, so just low-risk features, I would personally throw in, it's going to come up on the next slide, but I would personally throw in also patients who may have risk factors of more side effects from ADT, or just really don't want it. In that setting, embedded in the guidelines are low-risk features in terms of the cancer, in terms of salvage radiation, and I would put in either don't want or maybe have some comorbidities that we really want to avoid ADT. So the guidelines may offer radiation alone with those caveats. So this particular part of the guideline does have this SCM, shared decision-making, that's there, which is really embedded in terms of the entire guideline. Should discuss side effects, and what I'm talking about here is specifically side effects from the ADT, the systemic therapy, and we know about those overall. So there are references in the guidelines from a lot of data sets, including what I have here, the adverse events from the ADT from the individual trials. Obviously, when we look at 9601, which is high-dose bicalutamide alone, we have the gynecomastia that's much more common in that setting. But we know that there are cardiovascular, metabolic, et cetera, toxicities that can be present. So it's all a risk-benefit. So when we have the substantial benefit, including OS and met-free survival in some of the trials, I think risk-benefit favors the addition, but it's not that there's an absence of adverse events. Okay, so node positivity, pathologic node positivity has been discussed a couple of times. One of the questions was, what about starting ADT? So we have what many people refer to as the Messing trial, ECOG 3886, which, to remind you, was positive lymph nodes, adjuvant lifelong ADT or not. This was performed in the pre-PSA era, at least before the use of PSA. And that was an OS benefit, so New England Journal for that reason. So it did not necessarily include radiation. The McGill study included, was a study, non-randomized study of postoperative radiation, including the pelvis, with ADT that showed that it was safe and better than historical controls. And then a number of different data sets that have been looked at. So based on all of that, the recommendation is to include ADT rather than RT alone in the setting of positive nodes. So anyway, that applies to the question that was already asked. So if in the setting of administering hormonal therapy, what is the minimum? And really based upon the overall data sets, the shortest one amongst the published literature was the 4 months that was part of 0534. So That's where this, this guideline recommendation is a minimum of 4 to 6 months. It doesn't say that you can't do 2 years, it says a minimum of 4 to 6 months because of the available trials, plus a meta-analysis that looked at that. Meta-analysis, mostly it was 6 months because most of the shorter term durations were 6 months. But 0534 was allowed as little as 4 months. Okay. Longer term, what about that? So the primary big data set with an OS advantage was already mentioned, RTOG 9601, 2 years of hormonal therapy, happened to be bicalutamide, and there was an overall survival benefit. What else is there? So that's really what we have. I don't think, I haven't seen it, so it could have been recent, but so radicals was presented, and the publication was presented in terms of the early salvage versus adjuvant. But there's also some randomization of ADT that included different durations of ADT. One of them included a 6 versus 24 month, and that abstract points towards the benefit of 24 months better than 6 months. That was in the higher risk portion of that particular study. DADSPORT is also, to my knowledge, not published, but is a meta-analysis that includes radicals as well as the other data sets that says, well, maybe it's not such a slam dunk that 24 months is better than 6 months. So we don't really know, but there is some data, certainly RTOG 9601, but some data in radicals, and we'll see what happens in the peer-reviewed publication, that particularly for patients with high-risk factors, that you may extend the ADT for a longer duration. So this is a recommendation against. So should not recommend the addition of docetaxel in patients undergoing salvage radiation ADT. So no real level 1 evidence. The two references I have here are not really salvage radiation data. It's really biochemical recurrence, ADT or ADT plus docetaxel. 3503 actually was technically a positive trial statistically, but not clinically relevant because the benefit was small and there's more toxicity. So it's not something that we generally would recommend. I'm going to come to the starter trial. But overall, docetaxel doesn't have a current place in this setting. So for pathologic node negative, what about the recommendation for intensified systemic therapy? And the recommendation is as part of a clinical trial. So, you know, EMBARK, STAMPEDE, different data sets. There is an ongoing trial, RTOG 3506, that will see 2 years of ADT with radiation or 2 years ADT plus enzalutamide. So we'll see what happens with that. I'm going to walk you through some of the preliminary data, but I would say that, you know, really these are phase 2 data sets, which is why that the recommendation is for patients should do it on a clinical trial. So Salv-Enza is the one that's on the top, radiation plus enzalutamide, or radiation alone. Consistent with the other data sets of short-term ADT, there's a benefit from this ARPI in the setting, but there's no ADT in the other arms. We're not saying that intensified hormonal therapy is any better, that's just single agent enzalutamide. Formula 509 has been presented a couple of times, was salvage radiation with 6 months of hormonal therapy, but it was 6 months of ADT plus abiraterone prednisone and apalutamide, so a triplet type of a therapy versus ADT plus bicalutamide, the traditional combined adjuvant blockade, and really only trends for a benefit for the intensified therapy. This is randomized phase 2, although in the subset of high risk, there may be a benefit that's there, but that's a subset. So not quite ready for prime time, but maybe something, when we look at these larger data sets, particularly phase 3, maybe that's going to be the future. STREAM and STARTER were two different sequential trials that were done. STARTER was designed to build upon STREAM and compare to STREAM, but basically STREAM was the first one, which was salvage radiation with ADT and enzalutamide, so that combination, and it was safe and looked interesting. And then STARTER built upon that, not randomized, It's under peer review right now, but has been presented. That was salvage radiation with ADT plus apalutamide plus docetaxel. As I mentioned in terms of the chemotherapy, I was going to come back to that. So this is some evidence. So this was, retrospectively, it was prospectively designed to compare retrospectively, but these are sequential, not randomized trials, to look at that docetaxel containing intensified hormonal therapy, systemic therapy with salvage radiation, and it looked to be better than the ADT plus enzalutamide study, but single arm, really retrospective review, so not prime time. Okay, so in summary, when we are recommended salvage radiation, as a general rule, we would say we recommend the addition of at least short-term ADT. This is in particular in those with higher risk features. And I'm sorry, what I didn't mention is that the retrospective looks at these prospective data sets that leads to the level of evidence of adding ADT. When we look at them, one of the factors is the pre-treatment level of PSA. So the higher the PSA, the more often we would recommend that. We can discuss longer durations, particularly in those with higher risk. Intensification is currently for clinical trials. And then shared decision-making is really embedded into every single guideline, in particular where we're adding in the additional toxicity of systemic therapy. I think that's my last slide.
Awesome. That was phenomenal. Thank you. Thank you. No, okay. An amazing summary. Thanks, Scott. We have a few minutes for questions here. Questions about systemic therapy in this setting or any of those key trials that Dr. Tagawa presented? Okay, well, keep rolling. All right, so yeah, we're right on time. I'm going to go through we've basically covered, I don't know, 27 of 30 or so guidelines, and I'm going to cover the last few that we haven't gotten through, and we'll go relatively quickly through these because I want to spend plenty of time for the cases that we've got. And again, please come up with questions. And I know many of you see patients in this setting, and there's always a lot of nuance. So I want to talk about treatment delivery for non-metastatic recurrence after radiation. There are a couple of really key statements here. One is this clinical principle. So for patients with biochemical recurrence following primary RT or ablative therapy who have no evidence of metastatic disease and are candidates for local salvage therapy, clinicians should perform a prostate biopsy to evaluate for local recurrence. And I think this is sometimes overlooked or sometimes skipped. It's really important. We can get fooled. So we need to biopsy the prostate in this setting. Next, for patients with a biopsy documented prostate cancer recurrence after primary RT who are candidates for salvage local therapy, clinicians should offer any of the following. We don't really have good comparative evidence. Prostatectomy, cryoablation, HIFU, or re-irradiation as part of a shared decision-making approach. Of course, each of these has pros and cons, different side effects, different intensities of treatment. And really, each one should be, and any patient should have this discussion tailored to them and their urinary function, sexual function, overall health. So shared decision-making approach in that setting. Statement 25. In patients for whom salvage local therapy is being considered following focal ablation, clinicians should offer whole gland treatment by prostatectomy or radiation. Of course, this is a space where there are more and more recurrences because focal therapy is being done more and more commonly. Who should get treated in this setting, recurrence after focal therapy? It should be restricted to a subset of patients who have grade group 2 or higher disease, so we're not going back and treating grade group 1 disease. And patients should have a life expectancy greater than 5 to 10 years. But there is data to support safety of both surgery and radiation in this setting. Data are relatively limited, but they're there. The data are there. It's safe. The risks are increased, of course, compared to the primary disease setting. Next, clinicians may offer salvage pelvic lymphadenectomy for patients with evidence of pelvic lymph node recurrence after surgery or radiation. However, these patients should be counseled regarding the uncertain oncologic benefit from surgery in this setting. Sure, and we can talk about this. You know, I've performed salvage lymphadenectomies, I'm sure Dr. Bourgeon has as well. These are challenging surgeries. They are feasible, but the data to support their efficacy is really limited. There are some good data from Mayo to support consideration of salvage lymphadenectomy in this setting for select patients, but you know, one of the important studies that guided this guideline statement is a European series looking at single arm. We don't have good comparative data here, but looking at patients who underwent salvage lymph node dissection for nodal recurrence after surgery, and you can see the subsequent biochemical recurrence-free survival really just tails off. So fundamentally, we're not curing a lot of patients here, if any. And so the vast majority of these patients underwent a recurrence. I do have some of the Mayo data here. This is Jeff Carnes has led a lot of this work. And this study looks at patients who underwent metastasis-directed therapy versus ADT, not a randomized study, retrospective review, metastasis-directed therapy versus ADT, or salvage lymph node dissection versus ADT. Or so the MDT was the composite of patients who underwent radiation or surgery. And so you can see the hazard ratio there was 0.52. That was statistically significant. And then it's also, this data separates out those who underwent surgery versus those who underwent radiation versus ADT. Significant protective effect for patients who underwent treatment. Again, it's retrospective and all the confounders that we might imagine. So data to support it, that's why it's in the guideline and something we can discuss. But we really need to couch the expectations if we're going to recommend that treatment or offer it. Okay. So that's all the guideline statements. We got at least, I think, 20 minutes. We can go through some cases. And again, please ask questions. All right, case one. This is a 55-year-old gentleman. It's 2 years after surgery. He had PT3A, node negative disease. It was grade group 3. PSA is now 0.3. His PSMA PET is negative. Steve, I'm going to start with you. And anybody can chime in, but what are your thoughts?
Yeah, I mean, I would take this case under the assumption that the PSA of 0.3 has been repeated and confirmed at 0.3. So again, just making sure that we don't act on a single value. But I would say he's young. He's got a long duration since his surgery. He's got a PSA that's confirmed and a PSA PET that's negative. I would refer him to radiation oncology for consideration of salvage radiotherapy.
Okay.
Yeah, I largely agree with that. I would do the same. I would want to know like margin status for the patient. And, you know, with the PSMA PET negative, that doesn't matter given that he's young. I would, you know, also want to know if he's, I mean, I'm assuming hopefully he's recovered urinary continence, get a sense of his erectile function. But I would definitely offer salvage radiation therapy, but counsel him that, you know, there could be an effect on erectile function and, you know, after treatment. With regards to the nodes, so the N0, I would just want to know how many nodes were taken at the time of surgery, because all surgeons, from my experience, kind of take their lymph node dissections, it varies. So sometimes you could see 2 nodes taken. Sometimes you could see, you know, 16, 18, 20 nodes. So if I would definitely consider adding pelvic nodal radiotherapy, just given those additional factors. And I'd also want to talk to our medical oncologist about the addition of ADT.
Okay, so just a couple things there. So the margin status, if the margins are positive versus negative, does that impact your recommendation regarding whole pelvic RT?
Not as much. I don't think so. I mean, I would just want to know, because it just would probably, I mean, if the patient was really wary about adding a pelvic nodal field, I'd feel more comfortable, you know, omitting the pelvic nodal field if there was a positive margin, because then I would probably think more strongly that the recurrence is probably in the bed.
Yeah, bed. Okay. Scott, are you recommending ADT or patient says, I just do whatever it takes? You know, I just, give me the thing that you think is going to work the best.
So the shared decision making is part of it. I just want to mention that part of my pre-test counseling for ordering a PSMA PET for biochemical recurrences, I hope it's negative, and if it's negative, you should get radiation because that's the highest chance of a cure. So lower volume disease, always easy to cure. It doesn't really matter what the modality is. So that, I think that's a good take-home message. You know, one of the things that was mentioned at the beginning, but we haven't come back again, is additional additional tools that we have to risk stratify. So gene expression testing was mentioned, and that can give some prognostic information. But MMAI, so the multimodality AI interpretation of the pathology, is something that can give prognostic information, but looks like it also gives some predicted information about the addition of ADT in certain data sets, including this data set. So
Plug for my presentation tomorrow at 11 a.m. on
Okay.
Artera and the biochemical recurrence setting. Thanks, Scott.
yeah, that wasn't even planned.
Yeah.
So not available in New York, in California, I think still, but available other places. So anyway, that's some information there. 0534, you know, the median was 0.4, so some people would say at 0.4, that may be the cutoff where we really push it. But I would say you want to be more aggressive. I think that from a pure oncology standpoint, probably have a higher cure rate with the addition of ADT, but if he absolutely said, I want to avoid that, then that's his choice.
You'd be okay with it. Okay. And you'd give 4 to 6 months? So you'd probably give
Yes.
6 months, meaning, you know, in reality? Okay. Any patient says, I just want to wait for the PET to be positive. Like, there's no disease there. Anybody want to entertain that? And we made clear in the guidelines, don't do that. No, anybody want to do that? Okay.
It's kind of right at around the cutoff from Darian and Anthony's kind of retrospective look at it's probably safe to wait until it's positive around this level.
Yeah, and then
but
it's
higher.
not.
Yeah, exactly.
I don't know. Does anybody have any experience with the space where it's really tempting to wait? I mean, patient, like, I mean, we're friends here, right? We're like, let's be honest. Right? I think, yeah, Dr. Clear, right? It's tempting, but there's a window of opportunity here that we can miss. So, but
No, a question what you don't have there is, what was his PSA? This is 2 years later, because to me, in my mind, it's also different. Like, has his PSA been, all of a sudden, it was undetectable, and over the last 6 months, it's gone from 0 to 0.3, or, because in your guidelines, you talk about sometimes there can be some benign glands left where, you know, and I don't know how to interpret, I don't know how, as you were doing that, like, has it been going, you know, and I have some of these patients, like, has it been going, you know, 0.01, you know, like a little bit slowly going up year after year. So I think his previous PSAs would
it all
influence the
matters
decision.
for
too.
sure. And right, you can imagine we can at this point make up any story, but I think that's right. The PSA, the time to recurrence, interval from surgery to recurrence is important. The PSA doubling time is really important. Okay, go ahead.
Dr. Morgan, thank you, and thank you to the panel. I don't know if this is the right place to ask this, but how does things that we're hearing at this meeting, like the APA-RP, those trials factor into patients like this who have high-risk features? If we start incorporating these, you know, practice-changing papers into our practice with giving a year of apalutamide and ADT afterwards with a 0% biochemical recurrence at 2 years as presented yesterday, how does that change our recommendations in the salvage setting? I mean, if we're just pushing these patients who recur to greater than 2 years, and they've already gotten a year of ADT and a second generation ARI, does that change, you know, giving ADT if we're giving salvage radiation later? How does that factor in? I know this is just about your guideline and it was a mountain of work and looking at all this other stuff, but we have to factor in these next things that are coming out every year.
For sure. I'm calling Scott in a second, but so just a bigger picture, I think this is where guidelines meet like the latest evidence, and that's the challenge. These guidelines are truly evidence-based, based on published research. So even just an abstract like Formula 509, which we had, couldn't be considered for the guidelines. And so it's a really strict, for a good reason, about what evidence can make it into a guideline statement. There will be updates. AUA guidelines get updated, and when there is published data to support a change, it will happen. Now, in terms of boots on the ground, of course, we practice guideline-informed care, but every patient is different, and new data comes up that can change before the guideline gets out. Scott, any response to intensified treatment now?
You're talking about in that, if this is 0.3 after a year? I understand the study you're talking about. I'm not sure of the question, though.
Yeah, I guess the question is if you just take that 2 years after RP, if we just shift that, because now we're going to be shifting these biochemical recurrence, if we play this out and say, okay, now we're going to shift it to 3-4 years, but now they've already gotten intensified treatment after radical prostatectomy with ADT, how does that, just conceptually, how does that then factor into, do we still give ADT with radiation when they biochemically recur if they've already seen it right after radical prostatectomy?
So I will say the true statement is that I don't know. That being said, I would say there's kind of two aspects of it. One is that if they only have disease left in the prostate bed / pelvis, they're curable. So if they only had surgery and they never had any radiation, I'd say in my mind, it's got to be a much higher risk if they've already had ADT and plus intensified ADT. And I would definitely do a PET. If that showed nothing, then I would still go back and say, I'm extrapolating data. We can still take a look at, I'd send them to radiation oncology and say, hey, is this someone that you would consider radiation? In terms of adding ADT if they were going to radiate, in my mind, really what short-term ADT is doing is acting as a radiosensitizer. Maybe there's some benefit from the drug itself, but I think it's mostly as a radiosensitizer. So I would not necessarily withhold it for someone that wanted to be aggressive.
Awesome, thanks. Next one. This is a 6-year-old male. He's 6 weeks after prostatectomy. PT3A, node positive, grade group 4. PSA is 0.1. All right, so he's node positive and he has a detectable PSA. We see this a lot. Dr. Cameron, if you get this patient sent to you and, at the surgeon says just, talk to a radiation oncology colleague, you see them you see them at the 8-week mark.
Okay. Well,
And by the way, the patient, he's recovering, but he's using 2 pads a day.
yeah.
And he had good pre-op erectile function.
Yep.
Partial nerve spare and doesn't have any erectile function.
Okay. Yeah, this is a challenging case. I mean, given that he's 60, I'm guessing he's otherwise healthy.
Otherwise healthy.
Okay. So we would want to be aggressive in these patients. There's not a lot of data to guide specifically what to do with regards to radiation in the node positive, pathologic node positive disease space. There's ongoing trials. There's an NRG trial that's ongoing for this clinical scenario. And there's a lot of retrospective data that shows that there is a benefit. So of course, we have the Messing trial where you could just add on, just give ADT and lifelong. But we do know for patients that do receive radiation therapy, salvage radiation therapy, there are multiple benefits, clinical outcome benefits long-term. So because he's young, because he's healthy, we would definitely be thinking about salvage radiation, but not at this point in time. So we would want to make sure that the patient is recovering or has recovered continence as much as possible. So it's good that he's seeing us early, so he's getting plugged in early, given that, we would be likely thinking about salvage radiation therapy and systemic therapy. We'd probably get him started on systemic therapy earlier rather than later, and in that time, let him recover, especially the continence. I would counsel this patient that, given the systemic therapy, maybe put him on that trial, which escalates systemic therapy, so it's not just ADT alone, it's ADT plus apalutamide. Given that plus salvage radiation therapy, the patient may not recover erectile function at all in the future. So that's just something that I would really counsel the patient on. But assuming that he wants to be aggressive because he is so young, I think that it's worthwhile going forward with that. I don't know if anyone has thoughts.
Scott? Yeah.
I agree. I mean, this is someone who I would generally recommend longer than 4 to 6 months. Longer duration, although the minimum would be for 6 months, and probably start during recovery and go from there. I would also get a PET. So let's assume that he had a preoperative PET 3 months ago, meaning a month or so before surgery. I still generally get one just to kind of have an idea. And anecdotally, I've seen a handful that are positive, even though they're negative before surgery, or there was something that was equivocal that now, with more time, actually looks to be something, and particularly looking outside the pelvis just to get
Great.
that information.
Would you get that PET? It's PSA is 0.1. PET's very unlikely to be positive, right? It's, even though node positive, we know the rates of finding of MET here are probably less than 20%.
I was saying multiple data sets, including our own, is around a quarter.
Even at
of that.
PSA 0.1?
Less than 0.2, yeah. Between undetectable to 0.2.
But that includes 0.2, right? Doesn't that data include 0.2?
Correct.
So I feel like when you're
Less than. Depends on the
Okay.
data set. Ours we do
anyway,
less than 0.2.
so,
I don't think it's a
quarter
big
sounds
difference.
better.
But the main thing is that this is a different setting because it's right after surgery. So especially, it's a no-brainer, especially when there's something equivocal on the preoperative one. But they may or may not have a preoperative one. So I still get it.
You're going to get it. Okay.
Knowing that it's lower yield than
Yeah.
a 0.5.
Yep.
But it still may make a difference in terms of what we do.
But again, you're not waiting for that PSA 0.2 to start treatment. You're going to recommend some systemic therapy soon, now.
Yeah.
Steve, anything else to add here?
I think I might nuance it a little bit. I might ask how many nodes were positive. And here's what I was saying. I think the safest answer is you could start ADT now, wait for him to recover continence, and then give him salvage radiation when his continence recovered. I would definitely present that option to the patient because, as Dr. Cameron mentioned, there is missing data that says add ADT in an adjuvant setting, you improve cancer-specific and overall survival, and then you buy your time for radiation. So that would be the baseline beginning of the discussion. But honestly, we know that there are patients with a single node that's positive that are going to do quite well, actually, after surgery alone. He's only at 6 weeks. His PSA is only 0.1. So if he had more than one node positive at the time of surgery, I would put him down the pathway I just discussed. ADT now, wait for his thing. If he had a single node positive, and I would have a fair discussion with him about saying, we're at 6 weeks. And I would get a PSMA PET, actually, as Dr. Coward recommended, also because if we're thinking about ADT, it's going to confound it.
Right.
So if we want the PSMA PET, why not get it now? If he had a single node positive and a negative PSMA PET, and his PSA is 0.1, and he wants to wait 3 months to get more continence back, I would
You're
be
okay with
I
that?
would be okay with that. I don't know that he's absolutely committed in the setting of a single node.
Awesome. Great thought. So no doubt, tons of nuance here. Fundamentally, this patient is going to need salvage treatment, going to need RT plus ADT. Timing, maybe there's a little nuance.
I agree, and I think everybody for many years would be getting this guy loaded on the ADT radiation. And today, why not A, add abiraterone at some point during that, and B, agree with the imaging, because we have such great imaging today, but would anybody do germline testing on this guy at this point? Because it's going to come down the road. This guy is going to do poorly.
Germline testing, he meets the criteria for. So high risk or metastatic prostate cancer, you don't need to know anything else about family history. Should get germline testing.
Yeah, because this is the guy who's going to go on the PARPs.
Yeah, great. Thanks. All right.
Go
ahead. Yeah.
Sorry, just a quick question. I'm near Albany, New York, and one of our medical oncologists, we were always butting heads about his opinion that we overprescribe salvage radiation. That in a gentleman like this, or the last one, the chance of cure, statistically, even though it's the only chance of cure to do salvage therapy, versus just continuing to observe and talk about ADT, systemic therapy down the line. His opinion was that we were overprescribing salvage radiation, causing all these potential side effects in patients for a relatively low chance of cure. We had a lot of fights on this. I'm glad to see that it's, I think that's a bit older school thought, and he's actually getting ready to retire now. So we're running into that less and less often. But for a PSA of 2.1 at 3 months, the higher risk guys that are not going to do well, and chance of cure, even with a negative PSMA scan, I would still do it. I always counsel them. That's my opinion, what I would do, because it's the only chance of cure. But when do you not do it, I guess, is the question.
Well, I think that's, the nuance there gets into Embark data, for example, where you get really high risk biochemical recurrence, high PSA, and that's it, like that high PSA, super rapid doubling time, which is Embark, Presto. These are really, so those patients, we're talking about clear data for enzalutamides, right, plus or minus ADT, depending on how you read that. Less clear role for radiation in that super high risk setting. And that's basically, we're talking about, in many ways, non-metastatic hormone-sensitive prostate cancer, or at least non-conventionally metastatic, as far as we know. All right, case 3. This is a 70-year-old male, 6 months after prostatectomy, PT3B, N0, grade group 4. Initial post-op PSA was undetectable, and now it's 0.4. We get a PSMA PET, right? Yeah, so we're gonna get a PSMA PET. Boom, there's the PSMA PET. You can see a hot, he's got a bone lesion. Okay, so that changes things. Dr. Cameron, what do we recommend here?
Yeah, so that's challenging. So were his margins positive or negative?
Why you really always want to know the margin? My margins are always negative. No. his margin, yeah. Okay. I mean, that's a good one. I'd love to entertain both sets of possibilities.
So the question here is that so he has a recurrence. We're seeing something in the bone, and the question is do we think that there's something still in the fossa and in the nodes potentially?
Yeah. And there's nothing in the fossa on this scan.
Yeah, exactly. But the PSA is only 0.4, but that's always something that we always kind of talk about. So definitely he needs treatment. From a radiation perspective, the question is that do we treat just that met, or do we also treat the fossa plus or minus the pelvic nodes? That's the big question. If he had positive margins, I think there could be an argument to treat at least the fossa plus incorporate that lesion, especially because that lesion, it could all be incorporated in one pelvic field. So you don't have to come back and do a different type of radiation later on. If the margins were negative and there was really no other reason why he would have any type of local recurrence, then it's more questionable whether or not you want to do a fossa field plus or minus adding on those lymph nodes. I think this is something that we would, definitely counsel the patients on. I mean, for me, given that these fields they don't cause a lot of toxicity to patients, they tolerate it very well. If he was healthy, wanted to be super aggressive, let's say he had positive margins, I think it's worthwhile just going and being super aggressive, treating the fossa, incorporating the nodes, and also incorporating that lesion, I think. But you can have an argument either way.
Both
you
ways,
could also not be wrong to say, I'm going to just treat what I see.
Right. If it's easier, right? If it's a vertebral lesion,
Yeah.
and let's just assume it's negative margin now,
Yeah.
fine. Vertebral lesion, you're not going to treat the bed.
Exactly.
Right, at this point.
Yeah.
And I feel like when it's like right there, it's very tempting.
Exactly.
But I don't know, Steve, would you, because
Yeah, I mean,
obviously
these
there's
are
toxicity,
great.
we're adding toxicity.
We are adding toxicity. So I do would push back because of that. These are great discussions, and they're like, this is what is fun about tumor board. I mean, I would say that many at our place would do SBRT to that lesion alone, and might even, do it without ADT in a way to see if the SBRT to the bone alone takes care of things, gives him continued sort of stomp-esque window off of ADT, and have we accomplished what we hope to accomplish in metastasis-directed therapy. So again, you have at least molecular evidence of bone metastatic disease. Would systemic therapy be wrong? No. But, would it be, what would we probably do? We'd probably radiate the bone and see. And I mean, I would say that, there is some data from colleagues at the University of Chicago in radiation oncology that 35% of patients that get salvage radiotherapy for rising PSA have some evidence of radiation cystitis and hematuria, and that's not insignificant given its readmission and burden. So I don't think SBRT would carry that same toxicity profile.
Yeah, great. I'm going to keep going. Just one point, the guideline does allow for the omission of prostate bed salvage radiation in this setting. It's not a very distant met, but it's a distant met. Number 4, 67-year-old gentleman with PSA 8.1, clinical T1C, no negative, grade group 4 cancer, had primary pelvic RT and ADT. His PSA native to 0.3, then 1 year after ADT is completed, his PSA rises to 1.5, then 1.9 at 18 months. This does not meet the Phoenix criteria. Are you ready to work this up with a PSMA PET? You are, yeah, me too. Okay, so PSMA PET shows it lights up in the prostate. What does he need? He needs a prostate biopsy. Remember, that's an important guideline statement. Prostate biopsy confirms high-grade prostate cancer. Steve, what are you offering?
I apologize. How old is he?
Was he 67, yeah. So 67, he's healthy, life expectancy is 15 years or something.
You know, so this is what you, I mean, this is the discussion that needs to happen, which is he needs to be offered all, and the PSMA PET, no node avidity, no distant metastatic avidity.
Right.
Yeah, okay, so he's got isolated local recurrence after radiation and ADT. So I would have a discussion with him about salvage radical prostatectomy, being very fair about its comorbidity profile and its side effect profile with like a 45% incontinence rate, 40 to 40%. I would discuss with him salvage cryo. I would discuss with him HIFU. I would discuss with him reirradiation. And I mean,
Which
again,
would be high-dose brachy, Sophia, or, yeah?
Yeah, I like high-dose brachytherapy for these patients. They do really well in terms of their toxicity profile. Sorry.
Yeah, great. Okay, awesome, thanks. And last case, this is going to be, we're limited time, so I'm gonna do it as my own show and tell. This is a case of mine. 66-year-old who underwent prostatectomy 7 years ago. Patient of Dr. Clears too, actually. Let's see, remember this one? Gleason grade 3+4, P3N0. He had early salvage radiation, so already then got radiation. That was 1 year later. He had then slowly rising PSA to 0.8. He gets a PSMA PET scan. This was years ago, but we had access on a clinical trial, and it shows these two spots. And at this point, thinking, okay, like, I mean, I can go get those spots. I know it's that one on the left, thinking, you know, maybe it's like a peritoneal implant. And so go in robotically, do salvage lymphadenectomy, salvage pelvic lymphadenectomy, and did that one implant turned out to be a port site met. So that's a kind of view of the inside of the peritoneum. Port site met, 2 of 18 nodes were positive, exactly where we expected, right common iliac, and thinking, oh, that went really well, patient did well. What happened to his PSA? It went down and then it went back up, very much in line with the European study data that I showed with Bravi data earlier. So, and that was within a year. You can see the time of this, so pretty disappointing. And then we get a repeat PSMA PET, and it showed, you know, a bone met. This was a new lesion in the rib. So that's just an anecdotal word of caution again about surgery in this setting, and something that I think probably speaks of many of your experience as well. Oh, there it is, yeah. Okay, well, I want to end on time. Cannot thank you guys enough. Thank you for your contributions to the guidelines. Thank you for being here and educating all of us. I really learned a lot. Last thing is just a reminder you got to go in the app, fill out the post-test survey, and then you get all your CME credit, and we get feedback, and we appreciate any feedback. This is obviously the first time that we've done this course, so we're very open to feedback. Thank you.